Assalamu alaikum wa rahmatullah. Good morning, everyone. Thank you, Dr. Al-Ghanim, for the kind introduction. And thanks for SASLT and the organizing committee for the opportunity to talk today about alcohol use and liver transplantation. I focused on this practice in this region. I'll touch bases on contraindications for alcohol and liver transplantation. So, Dr. Gahtani, Walid Hmoudi, and I, a couple of years ago, said, why don't we look at the indications of liver transplantation in our region? And we looked over a span of 20 years, and you can see here, early 2000s, Hep C was the leading indication for liver transplant in our region, but with the development and advancement in Hep C treatment, we almost eradicated Hep C in our region. So rarely we see patients who are viremic going for transplant nowadays, but you can notice that fatty liver disease took the lead as the main indication in our region. So after the publication of this paper by 2 or 3 years, we performed 1,000 transplants in 2 or 3 years. So we said, why don't we go back and look at the indications again? So here you can see that, again, fatty liver is the main indication for liver transplant in our region. We still transplant patients for Hep C, but most of them are having negative viremia. But this is the first paper probably in our region that shows how many patients underwent liver transplantation for alcoholic liver disease. And in our cohort, around 7 to 8% out of our adult population had either alcohol-related liver disease or acute alcoholic hepatitis. And this is a paper from North America published recently showing that alcoholic liver disease is the leading indication now in the West for liver transplantation. So it's very important because now we are comparing MASLD, fatty liver, and alcohol, but we know that patients with fatty liver had a lot of comorbidities, primarily renal impairment, diabetes, etc. But most of our patients with alcohol are younger, they have less comorbidities. So you can see here that the risk of waitlist removal is much higher for patients with MASLD compared to alcohol. And the outcome and the survival while on the wait list is much better for alcoholic patients. So I'll just show you some examples from my clinic. So this is a 27-year-old male. He had a history of drinking locally made alcohol for 4 years. He had some sort of social stress, some psychiatric issues, so his drinking was worse 1 year prior to his presentation. When he came to my clinic first time, his bilirubin was 400. His INR was not too bad, and you can see his enzymes. The second patient, this is a 42-year-old female. She had a 10-year history of drinking whiskey, but she was decompensated when she came to the clinic. So she had ascites, endoscopy showed large varices, and she was jaundiced. And very important to look at the liver size. On imaging, her liver was very small and shrunken, and she had very significant thrombocytopenia that we thought it's related to portal hypertension and alcohol. The third patient was a male, 45. He was obese, but his liver is not too bad. It was enlarged in the ultrasound. He was not jaundiced. He had only slight elevation in his liver enzymes. He was drinking wine 3 times a week, 6 to 8 drinks at a time. The fourth patient was a 62-year-old male. He had 25-year history of alcohol drinking. He used to drink 1 liter of beer per night, sometimes vodka over the weekends. Again, similar to the second patient, he had ascites, he was deeply jaundiced, and his liver was very small and shrunken. So when we look at the first patient, he was drinking locally made alcohol. He was young. He was very sick when he came in. He improved with abstinence. He did not require transplantation. The second patient, she had liver transplant. Her son donated for her, but she's a female, and she had only a 10-year history of drinking, and she was drinking whiskey. The third patient was a male. He had another risk factor for liver disease, which is fatty liver. He was obese, but his liver was not too bad. The size was good, so he stopped drinking. He recovered. He's not following in our clinic anymore. The last patient, in contrast to others, he had a long-standing drinking history, and you can see his pattern of drinking. So you can see here that several risk factors play a role in the progression of liver disease. So the gender, the type of alcohol, drinking patterns, all are very important in assessing patients when they come for the first time in the clinic. So when we look at the global burden, we are still, one of the lowest countries, but if you look at the whole population, around 2.4 billion worldwide consumed alcohol. 40 of them reported heavy drinking episodes, And again, it leads to significant mortalities worldwide. And unfortunately for young people, it is still the leading risk factor for premature death and disability. So for prevalence of drinking in female, I think we have one of the lowest reported areas worldwide, similar to male. And when we look at the average standard drink, I mean, still in our region, it is much less than what is reported in other countries. So how much is too much? So when we go to the definition, one standard drink per day, this is the standard, one standard drink for women and two standard drinks for men, and each standard drink contains 14 grams of alcohol. This is very important when we come to the assessment. So the definition of drinks and drinking, so one standard drink has 10 grams now of alcohol, but harmful drinking is defined when there is a physical or mental damage, heavy episodic drinking, consumption of more than 60 grams of pure alcohol at one session, binge drinking, consumption within 2 hours of 4 or more drinks for women, 5 or more for men, because you can see here that women are more sensitive than men for alcohol. And this is just showing you the toxicity of alcohol per drink. But if you remember the first patient, he was drinking locally made alcohol. And as you know, alcohol is prohibited in our region, and there is a huge effort from the government to control such practice to prevent locally made alcohol. This is from the media. You can see how people make and manufacture locally made alcohol. It's extremely toxic. The concentration of alcohol is more than 50%. There has been, unfortunately, some reports of young people losing their vision, ending up in dialysis. Few patients died from methanol toxicity from such a practice. That's why the government is putting a lot of effort. We rarely see such pictures nowadays in our media. So what is the natural history of alcohol-related liver disease? So we have someone with chronic alcohol use. They have normal liver to start with. With time, up to 90% of them will develop some sort of steatosis. Around 40% of those patients may develop fibrosis. With time, around 20% will develop advanced fibrosis, cirrhosis. Unfortunately, 10% of them will end up having hepatocellular carcinoma. But the course can be accelerated with another underlying liver injury, mainly hepatitis C infection, but the course can be accelerated with Hep B, genetic factors, obesity, etc. So it's very important to assess for other liver injuries when you evaluate a patient with alcohol use disorders in your clinic. So alcohol abstinence is critical in the management of any patient with alcohol liver disease, whether they have early decompensation or no decompensation, because despite the stage of your patient, once they stop alcohol, their outcome is going to be better than someone who continues to drink. But what we see here is almost similar to what is reported in the literature, is the late referral for patients with alcohol liver disease, and it's been shown here in this paper that was published several years ago, that in contrast to other causes of chronic liver disease, alcohol-related liver disease patients usually have very late referrals, and they have very advanced disease stages upon presentation to transplant centers. So what was the 6-month rule? We always used to have 6-month rule for our patients to be considered for transplantation, but unfortunately, studies have shown that the 6-month rule has poor predictive value for pre-transplant abstinence. It led to a lot of healthcare disparities, and there was huge variation and inconsistent assessment protocols, different standards across liver disease. So you have someone with alcohol, he's being differently managed from one with autoimmune hepatitis or hepatitis B, and they used to call patients to go and get a random alcohol test. If he doesn't have someone to take him to the hospital that day, that sample will be considered positive, and he has to go back and count for another 6 months. And unfortunately, a lot of patients died while they were waiting to complete the 6-month rule. There was a lot of institutional variations in North America, Europe, and even in our region. So it's very important to screen your patients for other psychiatric illnesses, mainly anxiety, mood affective disorders. Very small percentage of our patients will have very advanced psychiatric illnesses like schizophrenia, which will be prohibitive of liver transplantation. And especially in our region, I believe that patients with chronic alcohol use will have the tendency for having addictions to other agents. We've had patients who were addicted to amphetamine, IV heroin, etc. So this paper in New England changed the practice for liver transplantation and alcoholic hepatitis, alcoholic liver disease, and they showed clearly that patients who underwent liver transplantation for early alcoholic hepatitis had much better outcome compared to others. But once a patient with alcohol got transplanted, their outcome is really good. So in this paper, when they looked at the long-term survival, patients with alcohol-related liver disease had almost similar or even better graft and patient survival compared to other etiologies of liver disease. So now, what do rates of return to drinking look like? Like what Francisco just showed in his slide. So his patient had one relapse before, he had one legal issues before transplantation while driving under influence. So in this paper by Brian Lee and the colleague, I mean, in their cohort, 70% maintained abstinence lifelong. Then only 8 or 10% had very bad and frequent relapses, and this was associated with worse outcomes. So if your patient remains abstinent, the long-term outcome is good, but all of us know that if the patient relapses after transplantation, especially heavy relapse, unfortunately the outcome will be poor. A lot of scoring systems are published and they are there, but I believe all scoring systems are focused on excellent psychosocial support, excellent family support, stable mental health, so no major comorbidity psychiatric illnesses, and the other legal consequences prior to transplantation. So what is the current practice? What are the regulatory systems here in our region, in Saudi Arabia in particular? So until today, I mean, alcohol consumption is still prohibited by law in Saudi, and this might have resulted before some patients will hide that they were drinking or underreport their drinking. So we may have low reporting here. But nowadays in the clinic, we don't have issues, and we show that 8% of our cohort had liver transplantation for alcohol. Again, because of overlap with fatty liver, I mean, some patients will not report. This might be a minor indication in our region. We have a lot of fatty liver and viral hepatitis. And I cannot find a unified approach between all transplant centers here in the region. I'm not sure about the practice in National Guard, the MAM, but I'm sure that most of the transplant centers now are not adherent to the 6-month rule. And we need more regulatory oversight, especially from SCOT and Saudi Organ Transplant, Saudi Center for Organ Transplantation. I don't know how many patients in the whole country had undergone transplantation for alcohol, what is the relapse rate, what is the survival outcome for such patients, because this is very important also when we discuss with our patients and their relatives. So what's the future for alcohol-associated liver diseases and transplantation? So with advancement nowadays, especially in precision medicine, hopefully that we'll have more accurate biomarkers, genetic profiling that will predict who's gonna have better outcome. This is very important. I think we need more effort, especially from higher administration, the Ministry of Health and other organizations, of integrating addiction medicine into the transplant programs, enhancing pharmacotherapy for alcohol use disorders. And yesterday we were talking about how can we best utilize AI and digital platforms in remote monitoring of our patients. And this also hopefully will eliminate any more health care disparities in our region. So in conclusion, overall and globally, it remains a global healthcare challenge. Unfortunately, those patients will present at a later stage, and establishing and maintaining abstinence is the key for much and better long-term survival. Early transplantation should be considered for patients who don't respond to standard of therapy. And this is just my personal view from my experience here at King Faisal, that what we have here in terms of relapse rate is much lower than what is reported in the literature. Personally, I believe this is because of the living donor programs. A brother or a sister will come and donate. The patient feels obligated to maintain and take care of this gift that gave him the advantage of survival. And I will conclude with this slide. Thank you so much.